Good evening. I am Dr. D. Silver. I'm a neurologist and a movement disorder specialist at Scripps Memorial Hospital in La Jolla, California. Tonight we're going to discuss Parkinson's disease, and we're going to focus on the treatment of motor complications. Now, not only do we need to cope with Parkinson's disease, but we really need to overcome the problems that Parkinson's disease patients have. So they'll have a better quality of life, better activities of daily living, and in my experience, there is always something we can do to improve the quality of life of Parkinson's patients. Tonight, my general thoughts about Parkinson's disease are going to be the first part of the talk. And then later on, we're going to talk about motor complications. What are they? They're motor fluctuations and dyskinesias. We're going to talk about how to avoid motor complications, these two important components of fluctuations and dyskinesias. We're going to talk about how to treat them, and we're going to talk about a new treatment called apomorphine sub-Q injection, which is a rescue type of therapy, which is a really significant benefit. Now, the key issues that I've found in patients with Parkinson's and managing their problems over the last 35 years have been that L-DOPA with carbidopa really is the most robust treatment format. It's the most robust drug we have. But the important aspect is to realize that when you give these drugs early with patients that have Parkinson's, you have significant motor complications. They occur early in the disease. And our clinical experience is, and clinical trials have shown, that when you have dopamine agonists compared to levodopa, that you have delayed motor complications in the group that have dopamine agonists first. So we use dopamine agonists as monotherapy. And this brings up the concept of the dopamine stimulation or continuous dopamine stimulation at the postsynaptic receptor site. This is the area where there is the action that takes place with the dopamine. In physiological states, normal physiological states, it's a continuous stimulation. But in the abnormal Parkinson patient, there is pulsatile stimulation. And we think this plays a role in motor complications. So we try to avoid pulsatile stimulation. We try to get continuous stimulation, and that's why we use dopamine agonists. And we use other treatments such as the MAO type B inhibitors and also entacapone to help increase the continuous stimulation at the postsynaptic receptor site. A new rescue therapy, apomorphine, a sub-Q injection, is very, very beneficial to patients, and we'll discuss that later. Now, it's important to understand patterns in neurodegenerative diseases. And most importantly, neurodegenerative diseases have what we call heterogeneity. Everybody has their own disease. It's a different kind of clinical picture. It's a different kind of pathological picture. The other important consideration is etiology. Parkinson's disease is a double hit phenomenon as far as etiology, environment and genetics. And we're only seeing the tip of the iceberg genetically in Parkinson's disease. Another important key factor of understanding treatment and patterns in patients is that exercise is a major benefit in patients. They do much better, they're healthier, and there's new evidence that you can increase trophic factors to the areas of the brain which have underlying pathophysiology. And we know that with time, that combination therapy here is really the best form of therapy, using combination therapy. And whenever we consider a drug, we think of the triangle of evaluation of a drug, and that is efficacy, tolerability, and safety. These drugs are safe, but what we want to consider is, are they efficacious and what is their tolerability? And we can help patients deliver a significant treatment format, and they can be tolerable and it can be efficacious. Also, we want to consider when we treat building on a foundation for the treatment of our patients so they get the best possible pharmacological therapy. And that is why we use adjunctive therapy, combination therapy, and dopamine agonists first. So treating Parkinson's, we think oftentimes of evidence-based medicine. and that's the clinical trials. And we're going to talk about that tonight. But also, I like to think of the theoretical reasons for using drugs early. And the theoretical considerations probably are just as important in many cases, especially if the drug has efficacy and tolerability and is safe. So the triangle for drug evaluation is very, very important. Now, Parkinson's disease is a progressive neurodegenerative disease. It's characterized by a slow, relative, selective loss of substantia nigra dopamine-producing neurons. It is a disease that progresses, and age is, most importantly, the greatest risk factor we have. Now, this cartoon shows us that in the midbrain, or the deeper part of the brain, is the substantia nigra. This is the area where this dopamine neurons are lost. Here we have a gradual deterioration or loss of cells. They become dysfunctional, and they don't have the opportunity to deliver dopamine up to the striatum, which is highlighted in this significant cartoon. Now, the classical triad of Parkinson's disease is tremor, bradykinesia, and rigidity. We call this the triad or the trio, and it usually presents with asymmetrical clinical features. Postural reflexes are lost only much later. And we know we can have an increased accuracy of our diagnosis if we have patients and look very carefully to see if they have asymmetrical presentations, if they have a resting tremor, if they have kind of a mass facies, and if over the years they have a robust, sustained response to L-DOPA. Lack of atypical symptoms such as dysphagia, dysarthria, early falling, and cognitive impairment is a very important consideration to realize when those occur, you may have a patient that actually has atypical Parkinson's. Now let's look here in a very nice animated cartoon on the sites of action of Parkinson's disease. First of all, we have L-DOPA. L-DOPA is present in the stomach. You take it by a pill, it gets into the stomach, it's passed from the gut into the blood, but into the plasma, and it has to go through a barrier. L-DOPA, we have to be careful not to take a lot of protein or it'll block that passage from the stomach into the plasma. Once it gets into the plasma, it can be broken down into the plasma into dopamine and into 3-O-methyl-DOPA. But fortunately today, and with the first Cinemet, we had the opportunity to block the pathway from levodopa to dopamine, and that gave us more available L-DOPA to go to the brain. But now, with entacapone and tolcapone, we can block also that COMT pathway by giving a COMT inhibitor, and we can get now, instead of 1% of L-DOPA from the plasma to the brain, we can get as much as 10%. So we have L-DOPA into the brain, and we can see that L-DOPA then is converted to dopamine in the presynaptic neuron, which is the neuron on the left. And then we have, from then on, we have the release of the dopamine to the postsynaptic receptor site. Now, other medicines that we use oftentimes are like selegiline or aldapril, which are MAO type B inhibitors, and they allow us to have more available dopamine. Rasagiline, a new drug, is also going to be able to be used, and that's an MAO type B inhibitor. But we also have dopamine agonists, mainly ropinirole and pramipexole, and they act directly on the postsynaptic receptor site. They have a longer half-life than L-DOPA, which is half-life is 90 minutes, and dopamine agonists are much longer in their half-life, and that gives us an opportunity to have more continuous dopamine stimulation right there at the postsynaptic receptor site. And that is where apomorphine also has its benefit. Now, dopamine agonists are very interesting substances and pharmacological agents. They act directly on the dopamine receptor that I showed you on that last cartoon. They are very effective in the treatment of Parkinson's. About 40 to 30% of patients can stay on a dopamine agonist for 5 years and still have a good therapeutic response. And the risk is much less for developing motor complications, which are of two types, fluctuations and dyskinesias. And now generally there's a consensus that initial monotherapy with dopamine agonists are very, very important. And we can use adjunctive therapy later on using dopamine agonists with levodopa. Levodopa, however, has been the cornerstone of the treatment. Early on in the 70s and the 80s, you had reduced morbidity and mortality. It's a very effective drug. All Parkinson patients respond to it. But as I mentioned, the problem is that you have a significant number of complications. Now, this is a therapeutic window. This is how the disease progresses. And there are 3 different segments to this cartoon. On your left-hand side is early disease, in the middle is moderate, and advanced disease on the right. What we have on the left-hand side is what we call the therapeutic window. And therapy is better in the green zones and as you go up. In early disease, we have a quick response. If you take the medicine, you have a good response, and there is a significant period that's prolonged of a therapeutic response to the drug. L-Dopa does a good job with that. And early in, you don't have much wearing off. But take moderate disease, the center part of this picture. We have here very clearly, we have moderate disease, the therapeutic window is narrowed, and we have peak dyskinesia, that little red peak. And that is when the patient develops these involuntary movements. And then as the drug wears off, we have more wearing off. Right there, kind of in the bottom in the right-hand corner. Now, advanced disease, you can see you have a narrowing of that green zone, or a therapeutic window, and you have more off time, which is in the bottom. And you have more dyskinesias. We want to avoid off time, and we want to avoid dyskinesias. Now, the risk of developing motor complications is significant. Young age, longer duration of disease, greater severity, high dose of levodopa, and short-acting dopaminergic medicines, especially L-Dopa, less so the dopamine agonists. Now, wearing off, that's that area in the picture I showed you. When the drug started to wear off, you would get wearing off or be off. It's an end of dose deterioration or a wearing off. And it's usually predictable. It's predictable, it has a pattern, it has kind of a rhythm early on. So here again is that very nice cartoon. Early, moderate, and advanced disease. You can see in advanced disease on the bottom, you have more wearing off. The drug doesn't nearly last as long, and you have more significant dyskinesias during the peak time. Now, what is wearing off clinically? The patient has to know, and the doctor has to get the message from the patient and the caregiver. What are the symptoms of wearing off? Slowness. We call that bradykinesia. Tremors. More increased tremors when you're wearing off or you're having end-dose failure. Or maybe in the morning, what we call morning off. You have decreased manual dexterity, difficulty doing buttons. You have difficulty with slowness. You may have posturing of your foot that's painful in the morning. Muscle pain, backache, shortness of breath, monotone voice or voice softness, and constipation. Now, very importantly, in the last number of years, we've talked about non-motor offs. These are symptoms that anticipate motor symptoms. And it's very important to key into this, especially for this new drug called apomorphine. Because if you take the apomorphine injection, when you have the anticipatory non-motor offs, you can reduce that off time significantly. So what are they? Numbness, aching, pain, hot, cold sensations, slowness, bradiphrenia, meaning slowness of thinking, dullness, dull thinking, sweating, anxiety, panic attacks, respiratory changes, and mood changes. These are non-motor symptoms that can be significantly noticed and recognized by the patient. And they have to definitely go ahead and communicate that to the doctor. So you can see here, when the patient is off, on the right-hand side of each one of these panels, that is when the patient may have the off time. But just as they're going from a therapeutic responsive state down that slippery slope, they may have that anticipatory non-motor symptom. Now, other motor complications that we talked about and have recognized are end-of-dose deterioration, and that's wearing off or off. Delayed onset of response is very important. You take the pill and nothing happens. That can be actually because the pill is still in the stomach, or there's some kind of delayed emptying, or the patient may never actually have an off time. So that's important to recognize. And there's this phenomenon called on-off that just kind of randomly occurs. You're on, you're off, you're on, you're off. And of course, this phenomenon called freezing, where you can't move. So for off, the patient needs to know, has to recognize it. They need help from their caregiver and their spouse. Then that message has to be communicated to the doctor. Then the doctor can titrate, individualize, pharmacologically optimize the treatment that patient is going to get. And that is really the art and the key to helping patients. And remember, non-anticipatory motor symptoms. Those are so important for patients. Now, I'd like to briefly mention a new drug that's going to be coming out called rasagiline. It is not out yet. On the earlier cartoon that showed the mechanisms of the drug, I mentioned aldopril and selegiline. And selegiline and aldopril are MAO type B drugs that inhibit the MAO type B enzyme, and it allows greater amount of dopamine to be present. Rasagiline is a new drug that's coming out. It's an MAO type B inhibitor. It's going to be coming out in 2 doses. It definitely improves Parkinson patients when they're on L-DOPA, but it's going to be also used as monotherapy. And it's going to help improve on time or reduce off time. It has very few side effects, and interestingly enough, this drug has had an interesting clinical trial where they've monitored placebo against rasagiline, an MAO type B inhibitor, for 6 months. And then they gave the placebo group rasagiline. And they found out that the placebo group, even though they got the active drug, rasagiline, later they never did as well or never caught up, so to speak, with the patients who were on rasagiline for a long time. That is called a staggered start trial. And what's that significance? Well, it may indicate that with some drugs we have an opportunity to have disease modification, or what we call possible neuroprotection. Have we documented neuroprotection yet? Absolutely not. But we're thinking about that, and that is one of the reasons I've talked about the issue of theoretical aspects and evidence-based aspects when you think about using drugs. I have a tendency to use drugs early in combination therapy, sparing the use of L-DOPA, using dopamine agonists, and then later on adding L-DOPA. Now I'd like to talk a little bit about a drug called apomorphine. It's a drug that's been released not too long ago. It's a very good drug in my experience. We did the clinical trials in my office here in La Jolla, and we found this drug to be a very good drug. It's a niche drug. It's a sub-Q injectable dopamine agonist that has a great opportunity to rescue a patient from their off time. The onset of this drug is very significant. It can occur after the injection in about 10 minutes, and it lasts 30 to 60 minutes or more. The side effects are not that severe, but you have the opportunity to tailor the treatment of this drug to the patient. So you start low, go slow, and increase the dose. It has to be given the first dose in the doctor's office, but it works very well. Side effects are nausea, yawning, nasal discharge, and some sedation. But again, you can titrate the patient with the dose, and you usually start at about 2 milligrams. Lasts for 30 to 60 minutes, and that's a good, robust response. They do as well as they do when they're on their L-DOPA the best, and that's a very important aspect. It's a rescue medicine. It gives you the relief when you're off. So you have an opportunity to do those things that you need to do. And in my experience, it has a good chance of delaying or avoiding deep brain stimulation. Now at Scripps, Dr. Kennott and I do a lot of deep brain stimulation. The university also does this. There are numbers of places that you can get your deep brain stimulation procedure done. But apomorphine is a great advantage of maybe delaying that significant procedure. Now this is a slide that on the left-hand side gives you the concentration of apomorphine. And the concentration is the red line. And as the drug is given sub-Q, the concentration increases, and you can see it peaks at about 30 to 40 minutes, and then it tapers off. The UPDRS score, which is a motor score, is in the white line or the yellow line, and that line goes down as the concentration comes up, meaning that with apomorphine, you get a good response, improvement in motor activity, and you really do well with this drug. This drug has a good rescue phenomenon, and it also has the opportunity to take significant number of hours of off time out of the patient's life. So you can select when you take it, you get the response in 10 minutes, and things really improve. The adverse effects have to be noted. You have to be careful of them, but you also have to be aware you can titrate the dose. You can get sometimes some sub-Q injection nodules with this. You can get some yawning, as I mentioned, some dyskinesias at the peak. Usually they occur within 10 to 30 minutes, and they can be quite severe, but you then ratchet down the dose. Somnolence can occur, nausea and vomiting, sometimes a little nasal discharge. Hallucinations and confusion, in my experience, is very, very uncommon. But we do see dyskinesias. We see hallucinations. My experience with this drug is it's a good rescue drug. If you go low and slow in the injection format, you get an opportunity here to reduce significantly a number of hours of off time. This drug can be taken maybe as much as 6 to 8 times a day. And many times people will do that. Now I'm going to show you a video clip of a patient who demonstrates very nicely and very robustly the response to a sub-Q injection of apomorphine. We first show the patient before apomorphine. Now this is when the patient is off. It's prior to the rescue drug. The patient is slow in movement, and this is when you want to think about using this drug. When you have patients wearing off from the dose, they have end-dose failure, or they have morning off. And you can see that this patient, prior to his dose, he is slow in walking, he has a mass facies, decreasing blink, he's somewhat stooped, he is slow or bradykinetic, he turns in mass or turns in one piece, and he has very slow repetitive movements. This is the patient who is in an off time. This is an ideal time to use this drug. Most importantly, the doses can be titrated to the individual response. After the individualized dose that this patient received, sub-Q, and after the 10-minute latency period, you can see that this patient has more facial expression, is standing upright more, is definitely smiling more, moving and walking better, and has more rapid movements. You can see this in a number of situations. Most importantly now, this patient has gone from an off time to an on time. The patient can now do his activities of daily living more easily and rapidly, and he has a better opportunity to have a better quality of life. The patient can, during this period of time, when he takes the sub-Q injection, have significant opportunity to do the chores in his everyday life. A robust response in this individual. And my experience is this is oftentimes the case in most patients. To summarize and review our talk on Parkinson's tonight, I'd like to point out again the concept of neurodegenerative diseases. Parkinson's is one neurodegenerative disease. Alzheimer's is also another neurodegenerative disease. They have heterogeneity. They each have the variance or the spectrum of pathological changes and the clinical picture. Everybody has their own disease. We need, as physicians and as patients, to recognize that and have an opportunity to tailor and individualize the treatment. We also have to know the etiology is a double hit phenomenon. Genetics is a significant aspect. We're just seeing the tip of the iceberg. As time has gone on, we're getting much more genetic picture here of these diseases. And exercise is a major consideration for all patients. You got to exercise, help yourself, and be of benefit. Combination therapy, L-dopa sparing are very important. And we also want to build a foundation that's the most ideal, appropriate, advantageous treatment for our patients. We have to think about patients who have comorbidity and cognitive impairment. Sometimes dopamine agonists aren't the best for that. But in other situations, we can use these drugs like dopamine agonists in early therapy, and they do very well, and then use L-dopa. We're really in a situation tonight where we've had a great opportunity, I think, to talk about motor complications. This is just a brief picture of that cartoon that I showed you about early, moderate, and advanced disease, and how the therapeutic window narrows and the off time increases, as does the significant amount of dyskinesias. The general overview really is we've got to individualize our treatment. Motor complications, we've talked about, there are two types, fluctuations and dyskinesias. Avoid them, treat them, use apomorphine as a rescue therapy, and we know that we're going to have a better opportunity to give our patients a better quality of life. Thank you. Good night. This series of programs has been funded by the generosity of the Bell Foundation in honor of Glenn W. Bell Jr., founder of Taco Bell, and by Elaine and David Darwin.